Okay, and share. Good morning. This is the draft of our paper. What if diabetes could be reversed for more than 6 years with a simple 30-minute procedure? Diabetes, the most common cause of blindness, kidney failure, amputation. Diabetes leads to heart disease, stroke, nerve damage, and more. This is from the diabetic complications listed by the Endocrine Society. Here is the news in our paper, which is it can be. Our paper shows that we can reverse diabetes for at least up to 7 years. We'll start off with a case report example. This is a thin diabetic who presented to clinic recently. Prior to the clinic visit, she had a hemoglobin A1C of 15% when she was seen by Dr. Kular and Dr. Manchanda and underwent a mini gastric bypass. And that was in 2018. She recently returned to clinic in 2024, and at that time, her hemoglobin A1C was 4.7%, a decrease of almost 10 points. Triglycerides were also lower as she had elevated, and she had no recurrence of her diabetes, no complications, improved quality of life, resolution of her sleep apnea, migraine, breathlessness on exertion. This is the example of the reason for our paper. We have seen this now in our series of 55 patients, and that is our report. The title is A Modest Proposal from Dr. Kular and Dr. Manchanda, and that is that thin diabetics are candidates for the mugga wugga wugga that they call it, or the MGB or MGB2. So this is from Kular, Manchanda, and Rutledge. This is the first successful long-term study. Oh, sorry. Long-term surgical therapy for thin diabetics. This is 52 patients for 7 years follow-up. And the mean hemoglobin A1C went from preoperatively 12.6 to 6.1. What we know now, what we believe now, is the MGB and MGB2 can be completely reversed, even in severe diabetics, for more than 5 years, and often off all medications. And that's what the purpose of the paper is. Okay, introduction is the treatment of thin diabetics 15 years later. India is in a deadly pandemic of diabetes now. Drugs only change the hemoglobin A1C by about 1%. And we know for 100 years, the Billroth-2 surgery has been a successful therapy for diabetes. That is, Billroth-2 leads to improvement or reversal of diabetes. The purpose of our study is to apply the MGB success to thin diabetics. And so that's what we're talking about in this paper. And we begin with a paragraph on India, the deadly diabetes pandemic, like you have in your paper. And here's some examples of what I would put in the paper. 77 million, one of the world's highest rates. 1 in 11 of all Indians are affected by diabetes, tragically, an economic strain of billions of dollars for healthcare. And so it is a national as well as an international problem. Well, you believe in not to say things negative about our brothers, but the medical treatment of diabetes is poor, with limited effectiveness and hemoglobin A1C changes of only 1%. And we need more than that for the sicker diabetics. And that led to the drive for us to do this case. So 100 years of the Billroth-2 led us to use this technique as it is a routine part of bariatric surgery. And we chose to use it under moderated conditions in these patients. Well, I will say during the rest of this, I call it an MGB. You call it a MOGA, whatever you wish. Remember, this is not new. This is 130 years old. This is not an experiment. What we know is with dozens and dozens of papers and dozens of studies, a Billroth-2 will lead to improvement or reversal of diabetes. Now, let's just say that again. This is nothing new. This is nothing new. We have known for 100 years a Billroth-2 in animal studies and human studies leads to reversal or improvement in diabetes. That is what we intend to show, and also show that under correct conditions, the results can be, in fact, remarkable. We can potentially save lives and protect our patients from the deadly complications of diabetes. And that's the motivation behind the study. For those interested, there's more than 100 articles with the Billroth-2 showing it improves or reverses diabetes. Because of space and time limitations, we won't go through them now, but suffice to say, there's nothing new under the sun. And in this study in particular, we're going to show unequivocally that these very sick diabetics with thin or normal hemoglobin, with normal BMI and normal body mass index can go from a deadly 12% hemoglobin A1C to 6, and to 6 over 5, 6, 7, and 8 years. When we get into we'll skip the background that you have in this, we'll use yours. Here's some of the data. This is the data. This is it. You don't need to read anything else in the paper. This is it. These patients began with a very high, an elevated hemoglobin A1C, and we'll show you in some of the upcoming graphs just how deadly and dangerous it is. But here, look at this. This is year 1, 2, 3, 4, 5, 6 for those patients who had this available. 7, 6.7, 6.4, 6.2, 6.1. What do we see here? What we see is improvement and then steady improvement for years afterwards. That was the example in the patient who came to our clinic, and that's what we see in these patients, a remarkable reversal of diabetes. You may not choose to call the word cure, and I accept that if you wish. But if this isn't a cure, I don't know, it's pretty darn good. So the power of the MGB in thin diabetics at 7 years, that's what the whole paper is about. We are trying to point out clearly, absolutely, and unequivocally that the thin diabetic does not have to be left alone on the island of medicines alone. We have better to offer. 94.5%, 52 out of 55%, had a hemoglobin A less than 7. This is life and death. Only 3 were above that, and these were 7, 7.5, and 8, nothing like their preoperative values. What this is, we see here in this graph, is life over death. Complications over no complications. As you might expect, older patients had worse outcomes. So on average, the younger patients had better results than the older patients, but both had excellent results. Both had excellent results. The other finding that's important to point out in this study, and I'm not sure we saw it in your paper, but I would put it in for me, is that we need to understand that delaying the treatment of diabetics may condemn them to the absence of cure. What we are saying here unequivocally is that if we think about what we know about diabetes, that delay can mean complications, blindness, heart attack, stroke, and death. Remember that pancreatic failure leads to beta cell failure and a decrease in C-peptide failure, and that is indicative of the diabetes now being irreversible. We know a low C-peptide indicates pancreatic failure of the insulin-producing beta cells. And if we lose this, we cannot cure those patients. And we can see that in this series. We see this, and what it leads us to teach and learn and talk to our patients about is before the damage of pancreatic beta cells have reached their maximum, operate, because we can reverse diabetes. We can reverse diabetes, but not after the beta cells have been killed off by persistent diabetes. Not after someone is blind. Not after someone has a dead or gangrenous foot. Not after renal failure, stroke, or MI. But what our data shows unequivocally is that we can reverse diabetes early, and later on, it is less able to be attacked. Here's the example. This is C-peptide, and C-peptide is a measure of function of the beta cells in the pancreas. If you look, the C-peptide then shows active beta cells here on the right and weak or absent beta cells on the left. As the beta cells die off, the ability to cure diabetes, that is a hemoglobin A1C in the fives, goes away. Here, with a very low hemoglobin A1C, we have a very low C-peptide. We have a high hemoglobin A1C because we cannot cure them. What this means to me, what this means to our readers, what this means to our patients is clear. Operate early before the beta cells are killed by the disease of pancreas. This study shows many things, but maybe one of the most important things is delay and death are the same thing. Act now, because we found this is a very low risk procedure. It can be done potentially with MGB2 in minutes instead of hours, and rapid discharge from the hospital. And this can be done, but not after we have delayed for years and allowed the pancreas to be destroyed. Here it is again, normal C-peptide between 0.5 and 2. Once you get below that, we get to the death zone. Once the pancreatic cells are dead, the beta cells are dead, we cannot cure those patients. We still can improve them. We should not hold it from them. But this is where we want our patients to be. A hemoglobin A1C of 5, a hemoglobin A1C of 5, a hemoglobin A1C of 5. I don't know, but I say that's reversal, maybe cure. Act before the low C-peptide. That's what I say. That's what we see here, and that's what we wish the readers to understand. Of course, there's more to show here. That's as you get older, the hemoglobin A1C ability of cure goes away. But look, it's still wonderful. This is still good. Even at age 60, it doesn't mean we turn away from them. We still have much to offer to keep them off of their insulin, to keep them off of the deadly complications of diabetes, which we'll talk about. Now, there is this discussion of BP limb length. And there was a lot done here for BP limb length. And BP limb length, we found, does not make any difference. Here is what we... Oh, we're still recording. Okay, we'll come back. All right, so we'll go here, and we'll go share. But I mean, you can see there's some good ideas.
This idea is very good.
Okay, so now we're back. And pre-op hemoglobin A1C and select. This is BP limb length and hemoglobin A1C. So this shows that the surgeons chose a longer BP limb length for different patients. But it shows also, as we're going to see, it doesn't make any difference. So it doesn't make any difference. So BP limb length has nothing to do with the HbA1c at 7 years. So there's no association between BMI and delta hemoglobin A1C. That's a small number. They're all in a narrow area. You don't have to worry about bypassing too much and malnutrition. And we're going to talk about that. So those of you who don't know what you're talking about and you're idiots, oh, we can't do an MGB on a diabetic. They're wrong. So let's look at albumin. So here's the albumin level at 7 years, and they're normal. Hemoglobin A1C is low, and albumin levels are normal. There are 2 people with slightly low, but no malnutrition. So nothing to worry about there. And if you want to get all excited about it, shorten the BP limb, because the BP limb of 190 seems to be a lot for the thin diabetic. So that's okay. Don't worry about it. It's nothing to worry about. If you're worried about it, you're a Roux-en-Y doctor, and so you're never going to be right. There's no association between pre-op BMI and the HbA1c levels. So these people are all from one BMI area, and it doesn't make any difference on outcome. It's not that. So pre-op BMI doesn't make any difference. There's no association. The pre-op BMI doesn't make any difference. You don't need to tailor the BP limb length. Don't need to worry about it. This is just a Billroth-2. It's a regular Billroth-2. We do it all the time for antrectomy and Billroth-2, for gastric cancer in the Orient, and for ulcer disease in the distant past when Kular, Manchanda, and I were young. So no patient has, okay, there's nobody has less than 200, no evidence of malnutrition. So this is the Billroth, and let's just look at the Billroth numbers. Now, I'm sorry, this is B12, okay? No patient is less than 200, okay? No patient is less than 200. And if you look, the blue line is preoperatively. So the B12 is made better by the bypass because they eat more healthy instead of crap. And so it's not a fear. Stop worrying. It's just a Billroth-2, and then eat healthy post-op. Okay, now, what's another topic, which is that the BMI is normal. Look at that. Everyone is normal. They go preoperatively from slightly, but these are all perfect BMIs. They are perfectly healthy. Their weight is normal, ideal, healthy weight between 18.5 and 24.9. 95% are within that range. That's what we want, and that's what we got. And people are going, oh, you can't do an MGB on because no, wrong. Okay, just don't do a real long bypass. Okay, now, what can we say about this? What can we say about this? So we went to Google Gemini and we said, let's do a linear model of what we know happens based on HbA1c. In other words, we know that HbA1c, as it goes up, the patient is sicker, and for example, they cost more. So we did this analysis, and let's look at the expected outcomes done by linear regression analysis with the Gemini. Thank you. Comparing the estimated projected diabetic costs. So wouldn't we like to know what difference have we made dollar-wise? I mean, we are a company, we are a person. What about money? Okay, well, let's look. So it turns out the costs come from the things we know, which is medication and supplies and complications and all these things. So we can, using a linear model, predict what the costs are going to be based on hemoglobin A1c. Hemoglobin A1c is a predictor of illness and death, and so more illness, more costs. So if your hemoglobin A1c is less than 7, our analysis with Gemini says the cost per year is between 20 and 30,000 rupee. That's Indian rupees, yeah. If you're 7 to 9, it's 30 to 50,000. And if you are greater than 9, it's $50,000 to $80,000. That's and I'm sorry, Indian rupees. All right, let's use this and look a little further at our patients, okay? The hemoglobin A1c less than 7% gives you a cost per year of 2,000 to 3,000, and I went back to US dollars. The hemoglobin A1c of 7% to 9% gives you a cost between 3,500 and 6,000 US dollars. And if it's over 9%, it's 6,000 to 10,000 US dollars. So now we understand what we're doing, which is if you're sicker by HbA1c, it's going to cost more. Now we know in our study, we lowered the hemoglobin A1c. Let's use this analysis and predict what happens. So for 10 years, hemoglobin A1c less than 7, that's 40,000 to 65,000. Hemoglobin A1c less than 7, well controlled, established 10-year cost, $20,000 to $30,000. The hemoglobin A1c for 9% or greater, 10-year cost is $60,000 to $100,000. So the two differences, 20 to 30,000 or 60 to 100,000. So if you look at that difference, if you're less than 7 or greater than 9, the 10-year savings is between $40,000 and $65,000 a patient. So a lot. Now, if we plotted this out based on the patient's preoperative HbA1c, because they're 10, 11, 12, up to 15, then they would be blue. This is, again, using the analysis from the Gemini. They can be costing up to $2.8 billion to take care of these patients. On the other hand, because everybody down here has a hemoglobin A1C in the 5 to 7 range, their total cost is just about 1 billion. So the savings, if this is all correct, is estimated at almost $2 billion in US dollars.
It's million. 2.8 million.
Thank you.
Yeah.
Right. Sorry. Sorry. Okay, good. All right. So that, okay. Now, here's the 10-year medical costs. Okay, 55 patients, 4 million, thanks. MGB estimated only 1.5 million, savings of 2.8 million. Why should we do this? Why should we be interested in this? Is it your money? Is it the government's money? Maybe the government wants to get involved in insurance company. See, somebody's losing that money. Somebody's paying.
Nation.
The nation. Diabetes is a deadly disease, 100% plus risk of severe cardiovascular disease. So again, we asked, what is the chances of having a heart attack? According to Gemini, using the predictive power of the hemoglobin A1C, because if your hemoglobin A1C is high, you're more likely to have a heart attack. And so we asked to calculate that. And for post-op, everybody, because they had a hemoglobin A1C of less than 7, they had a 0 predicted risk of heart attack. Well, what would be the risk if we didn't operate? Well, here's 100% chance. They were all predicted to have more than 100% chance. They all, according to this, it's not perfect. They are all likely to have a heart attack. And so you tell the patient, we don't have to do your surgery. You can take insulin and a GLP-1 drug and things like that. But unless you get your hemoglobin A1C at 7, which you're not, then you're going to have a heart attack. According to this, it's not perfect, but we're saying the risk is high. Okay. How about we cut off your leg? How about if we saw off your leg? The risk of amputation after the surgery, pre-op, post-op amputation risk with a hemoglobin A1C, the risk here is less than 6%. And here it's 10, 12, 14%. We will cut off your leg, or we will not. I wonder if that would make me want to have the surgery. This is the same data. Okay, now there's a very big study, the United Kingdom the United Kingdom prospective diabetes study. They found that the death rate of their patients changed when the hemoglobin A1C changed by 1% versus comparative therapy. Their best they could do, the hardest they worked in this study, they changed the hemoglobin A1C by 1%. We laugh at 1%. So we can use that data. We can say the mean delta hemoglobin A1C for this study was 1%. Okay. And the hemoglobin A1C delta in our study is 6.6%. I don't know multiplication, but I think that 6 times 1 is 6. That's 6 times different. Now let's use that data to predict risk of death. We decrease death. We decrease death.
Very strong slide.
They do not decrease death. They do by 1%. And then I have more. I haven't done this yet.
Very strong slides. Powerful.
Okay, this is cleanup. We're done. MGB2 has a success in the treatment of thin diabetics. There's knowledge and experience with the MGB. It's done all over the world. The selection criteria, we believe from this data, is operate early. And we can treat all ages.
Yes.
Minimum to severe thin diabetics. Kular and Manchanda's data preoperative mean is 12 plus, and at 5 to 7 years, it's less than 7. And every year after the first year, the hemoglobin A1C goes down. from a high 6 to a low and normal 6.
Which if we are excused, can we call cure?
I said, conclusions. It routinely improves or reverses all diabetics. A short BP limb means there is no or minimal deficiencies. Fear of deficiencies are by inexperienced surgeons who do not know what a Billroth 2 is. The operation can be as short as 20 to 30 minutes. It's safer and more effective than medications. And the answer is operate early to save the beta cells.
Great.
Thank you all very much.
Nice. These are really strong slides. Very good
No.
analysis, very good analysis.
How would you share this with me?